What's up, guys? Welcome to the ICU Nurses podcast with your hosts, Matt Slarchik and Peter Findero. This is a podcast where we tackle hot nursing topics, one conversation at a time. What are we talking about today, Petey?
Well, today, Matt, we're going to talk about this one drug that the World Health Organization is considering a wonder drug. It's on the list on one of the most important medications in the world, a drug called ketamine. We're also going to talk a little bit about the ICU, some medications in the ICU, and how things are done in the ICU.
That drug, Special K is what we call it, or they call it K-hole on the streets. But before we get to that topic about ketamine, guys, give this podcast a 5 stars, please. You guys have no idea how much it helps us. It helps the algorithm. It helps us get more ranked, more views, and ultimately we're going to deliver higher quality content to you. So give us that rating. Take that time out of the day. Me and Peter would really appreciate it.
Exactly. If it's not 5 stars, don't waste your time. Just, go do your thing. Go do some dishes.
Also, if you're on YouTube, thank you for listening. Subscribe to that. Keep up with us on the gram, on Facebook. We're doing more and more. So we're working on a couple first product that we're going to release soon, right, Petey?
That's exactly. Yes, sir, Matthew. How's San Diego treating you?
It is doing well, man. The weather's kind of chilly. It's been a low of 40s here, surprisingly. So today wasn't like a shorts weather. It was like a long sleeve pants sweater. But it ain't that too bad.
Long sleeve pants weather, huh?
Mm-hmm.
It's 25 where I'm at right now. It's more of like a double the pants with some joggers, 2 t-shirts and 2 hoodies and a jacket kind of weather over here.
Damn, I don't miss it one bit. But even though I'm flying in for the holidays, and this podcast is going to be live right before the New Year's, guys. So hopefully everybody's thinking about their 2020 intentions and everybody's hyped up for 2020 because I know I am.
Good for you, Matthew. Good for you. Any goals for 2020?
Of course. I'm always trying to become a better version of myself, but definitely want to take this right here to the next level. So that's my goal, professional level, just travel nursing. And yeah, how about you?
Yeah, same concept, some travel nursing. Get this NCLEX checklist out before May would be ideal.
Mm-hmm.
And see where life goes, I guess. But on today's episode, so ketamine, guys. Ketamine was popularized back during the Vietnam War. It was used majority as an anesthetic for people that got shot, that were wounded in war. So they inject them with this drug, got them numb a little bit. Hopefully, they got the care that they need afterwards. So ketamine is actually a NMDA receptor antagonist. So that's the reason behind why it's used as anesthesia and analgesic as well. But now, as time moves on, we know psilocybin is getting used for depression. Now they're trying to do some experience with ketamine, and it's been showing some pretty good results. Some studies have been showing some positive results with depression, major depression, and also depression that's resistant to other drugs like SSRIs and tricyclic antidepressants.
It's crazy how California is making a revolution here where when we were just in Oakland, they legalized what's called psilocybins. And now these trials are being tested out for this dissociative drug, which is in the same drug class as PCP, guys. Like it causes hallucinations. And we in the hospital where I'm working at, they're already starting modules and they're starting to use ketamine therapy. So not only is it for what is it called? The major depression, which we're going to talk about in the studies. It's also used as a sedative for surgery, and you could actually induce people while they're intubated with ketamine. I haven't seen it personally yet, but it's going to be pretty cool to see how it works better than opioids or like propofol.
Yeah, it's actually really cool to see because I like this idea of drugs that we have been working with the past. Like psilocybin has been around for many years. So has marijuana, and they're legalizing those things because it is showing some kind of a benefit, because we all know that these pharmaceutical drugs that we currently have, they do a decent job treating people, but there is a subgroup of people that are resistant to these drugs, or these drugs are just not doing enough. So, here comes in marijuana, psilocybin, and now ketamine for, PTSD, depressive disorders, and just like anybody with like any kind of psychiatric illness in the future. I know bipolar is also getting treated with these medications, and it's good to see because these meds have been around for a very long time. So I feel like we have a pretty good clinical grasp on them. It's more of like, how do we make these things safe in our, I guess I would say, how do we make these things bioavailable and safe at the same time in our bodies? So we kind of got to experiment with the dosages, see what kind of works, because like ketamine in high doses, it's a sedative, it's an analgesic. It numbs you and it can potentially, make you stop breathing. We use it to induce surgery and induce like intubations. So we obviously can't be giving this drug out just to anybody because it's obviously going to have those effects like morphine. Morphine, what that turns to is a lot of people use morphine, then it turns to heroin as a street drug, and people die from, respiratory depression and eventually stop breathing. So it's good that we're doing this research, and I'm glad that it's actually happening, but we still got to find out a lot about the safe dosages. Is it something that we can only do in the clinical space, or something that we could now use, maybe go from IV to a PO version that's safe over the counter, not over the counter, but safe to take at home? Because right now ketamine is not used outside a clinical setting, correct?
Yeah, so the one medication that's being released by the FDA after drug trials, it's called S-ketamine, I guess. And guess who made that drug, man? Johnson & Johnson.
Of course, dude.
I know they always get their first little, I wonder who they bought out. But anyways, the way this drug works is it's used as an add-on to antidepressants. So the only way you could get this drug is if you're to 30% of the population that SSRIs or antidepressants hasn't worked. So what you do is you take this on top of your antidepressant at SSRI. And what happens is they have been having great success rates. They're calling it one of the biggest breakthroughs in depression research. So I wonder if this could be used as a over-the-counter, because right now you have to go to your doctor's office and take this dose, and he has to administer it, correct? You can't just take it home and be sedated, technically.
Yeah, I'm pretty sure it's, I'm not sure it was a physician or a psychologist or a psychiatrist, but you do have to be with somebody else in like actual clinical setting. You got to go into the office and take it in the office and go through it in the office, because it's I think it's like 45 minutes of an effect.
Something like that, and you have to kind of sign a waiver that you cannot drive yourself home. Someone has to pick you up. Yeah,
that's very true. It's a dissociative drug, so it does produce euphoria, can produce hallucinations. Obviously, we don't want you tripping balls when you give this medication, but that plays a role into your antidepressant maybe, and like unlocks different neural pathways in your brain. And a lot of times, it's not just they give you the medication and they let you just lay through it. It's they talk to you. They use like different kind of talking strategies, and they kind of work with you through your high, essentially.
Yeah, that's what I'm thinking too. And they have actually tested this on like a 16-year-old boy. It was like a 2017 Yale study, and this kid basically tried to kill himself at least 3 times. And after taking this ketamine infusion, his symptoms literally reduced, and he had no longer suicide ideations. This is just, of course, clinical trials. It's not like being given for suicide, but hopefully in the future, this could be prevention of, right? Not prevention of, but just like a bad way, a last ditch effort to help somebody with suicide.
Yeah. I mean, of course, if it works, why not give it to them, especially if it's like this last ditch effort. I'm not saying ketamine is going to be a last ditch effort for everybody. It might be, first line, but this is how these medications start. So you got to first do research on the subgroup that doesn't respond to our current standards of care. And that's kind of where we should move forward, because you can't just test it like the public with it. You got to start small and then move on. There's one study that I read. I didn't fully read it because you got to pay to basically buy this article, but it was through Harvard University. And they actually experimented with ketamine with individuals, and it showed a 60% response rate within like 4.5 hours. And I think the week-long response rate was like 30%, which is actually, it was like, I believe it was 40% or a response rate for a week. So these people, so one dose of ketamine kind of helped them through a week's worth of depression. And like I said, this depression was either major depressive disorder or it was a depression that was resistant to other kind of medications. And they did, it was conjugate with current recommended medication, like SSRIs and tricyclic antidepressants.
It's interesting how we're moving, because, during the 1900s, I'm not sure the exact dates, right? It went from trying like LSD and all that research, and they completely halted any kind of research. And it wasn't until like the 2000s now that we're starting to see the re-emerging of all these drugs. And for like the longest time, alcohol was the answer, which was, given to us and all the shelves, all the gas stations. And we're starting to realize that it's freaking bad poison, man. So I wonder if the next few generations, we're going to have a society that's going to be totally different on what it's consuming and stuff like that. Because look at like cigarettes, right? Like, dude, now nobody smokes cigarettes, man. It's hard to see. Everybody vapes or doesn't anymore.
Yeah, that's true. Like, look at the medication your parents had. If you could, it's kind of hard to recall because we're younger, but back then, like, think of antibiotics. They were used religiously. Like, everyone got an antibiotic. You see a doctor, they give you an antibiotic. Then they found out that is making a huge difference on these like antibiotic resistant, bacteria or cells, and it wasn't doing any benefit to viruses. So now they're cutting back antibiotics. So antibiotics are still fairly new. So as long as we give this medication to society, we keep doing these trials, it's so many times only going to tell. I mean, later on, we never know. We could find out that ketamine is completely pointless or completely doesn't work. Maybe it's just like a metabolite of ketamine that's actually producing an effect, and not just actually not ketamine as a whole. And we could just target that and give that to people. You never know what's really going to happen. But it's crazy to think about that ketamine is on the World Health Organization's. They have a list of like most important medication like in the world, and ketamine is on it. Oxygen is also on the list. Morphine's also on the list. Versat's on the list. Ketamine is on the World Health Organization list of most important medications, clearly for its analgesic effects, but maybe it could be on there for its antidepressant effects. I know there's two different derivatives of ketamine. There's like an S type and a K type. And the one that you mentioned, the nasal spray, it's actually the type of ketamine that doesn't work as well as the S type. So like I said, you got to try these things out. And then this is how it works. You try out these medications, and then you kind of learn what part of the medication actually does these certain things, and you isolate it. And then that's what you kind of give out to the public. And that's how you target different diseases and different infections, things like that. But this process, it's a whole long process. And I'm sure if it shows some benefit, even if it helps only like 5% of the population, or even 3%, why not? Why not to give it to them?
And I think that's definitely going to be a push that we're going to see in the next few years, because look how psilocybins are progressing. So anyways, since we're talking about ketamine and we mentioned it about the ICU, how about we jump into what to expect as an ICU nurse? And a lot of people that work in the ICU, they could benefit from this to kind of get a perspective of how maybe we do things. And if you're a nursing student wanting to get into the ICU, this is going to be perfect for you to kind of figure out the day-to-day routine and or night-to-night routine that me and Petey have, and something that you might expect.
So the obvious first biggest difference between the ICU and the general floors is the patient ratios. It's usually 2-to-1, 1-to-1. Occasionally there's 3-to-1 if your house is ratios, which does happen, but it's unfortunate, but that's how life works. And it's more hands-on care. You're the one usually doing the turning. You're the one doing the bathing. You're the one doing the vitals. You're with the patient the whole shift. You provide the primary care. You do the times. You know how the patient reacts when you turn to the left side. You know how they react when you turn to the right side. That's why it's 2-to-1 instead of having your 5 or 6 patients, because you're fully with that patient. You should know everything from head to toe, every response, what that patient is doing when you do every little thing. Like, when you flush them or flushes NG, when you flushes PEG, you should know exactly how that patient reacts to everything that you give to them.
And usually, just because you're working ICU, just like you said, patient-centered care, you're doing everything. And literally every single ICU, I've been noticing that there's no tech. So we're mostly doing all the work, which is okay, because we need to be on the freaking trigger with everything that happens, like on the dot, just to kind of know how the patient is progressing. But I feel like, and I noticed, like, did you ever notice there's a lot of like OCD in nursing, like ICU nursing?
Yeah, there definitely is. I know I'm not the most neat person when it comes to the layout of the room, but I know some day shift nurses are. I mean, I'm pretty decent, but there's some nurses that are more OCD than I am about how the room looks. And I mean, I know everything is, and each moment it just doesn't look as organized as somebody else's. So it's kind of interesting to see when you leave and you come back the next night and your room was like completely neat or completely organized in a different way, because you're only there for 12 hours and you kind of make that environment to your liking, but then next nurse comes and then they make that environment to her liking, and it kind of just goes back and forth.
Yeah. And it happens all the time with like the littlest things. So when the shift starts, and we could talk about everything that we do, but one thing that I like to do is always look through like my lines, and I like to kind of like sometimes put them in the right spots. So if I have a patient that's on like specific pressors, I like to align my pressors a specific way. I always like to have levo always plugged in first, then like epinephrine, and then vaso or something. Just depends why citing it, but that gets into the nitty gritty. But that's one thing that I noticed that probably could change between shifts.
Yeah, from my lines, if I mean like 3 drips isn't that hard to manage, but once you get into like 4, 5, 6, 7, things like that. But when I have a lot of drips going, I label the line itself. I take a white piece of paper. It's like a sticky.
Oh, and just kind of put on the line.
Yeah. So I put that on the line with the medication name, and then also on the channel where it's on a channel, I put another sticky. I put clear tape because it's so easy to pull off. I put clear tape and I write where that's going to. Is it going to the intro? Is it going to the RA? Is it going peripherally? Just so I don't got to keep looking, like I don't got to keep following the line. So the line tells me what medication is going through it without actually looking at the medications. And then just by looking at the pump, I know where each med is going. So I can always move stuff around real quick like that.
Yeah. So I do it the same way. But now that since I work here in like San Diego, I'm not getting critical patients, man. Some of these ICU patients are like a joke. And it's unfortunate because I'm losing my skill, but I don't have to do that lately.
Are you sure you want to say that? You want to knock on wood or anything? Because you're going to have that night next time you go to work. People hear you talking shit. They're going to crash on you now.
I feel the energy. I'm manifesting an easy day, and look what's happening. It's going to just hit me, possibly. So we're starting the day, right? As ICU nurses, Pete, we always have our meetings. Let's not forget that before we even start the shift. We get to hear about how the unit is doing, the last fall, if there's different news of the week, right? We usually say a prayer sometimes. And sometimes we hear about all these patient scores, patient satisfactions. Tell your patient you do hourly rounding because these scores. That's one negative thing about nursing. You have to hear all this management stuff when you walk in, but ultimately it pays their pockets.
Yeah. I mean, the meetings are the meetings. If I'm there for like 3 in a row, it gets repetitive. So I kind of tune out on like the last 2 nights. Like things don't really change too much if you're there for 3 in a row, but you should at least listen to the first day.
Yeah, the first day, definitely. It's a little different here because I don't feel like I'm as completely part of the team fully, but I still kind of listen to everybody. And that's another thing. It's only been a month and I've been floating like 50% of the time. So I'm still trying to get used to my environment in the ICU. Like it doesn't feel like home yet. That's the only thing. Like I'm still like disassociated. I'm still that traveler. So I'm kind of getting there.
So what's like the major difference between the ICU where you were at in Illinois versus ICU where you're at currently?
Well, the biggest difference is, of course, the brakes, right? When it comes to the equipment, the pumps are a little bit different. They don't take a lot of patients like carotid procedures. So it's a little bit of not of as aggressive ICU, I would say. But there's some patients that I've seen in like violent restraints. I'm like, whoa, I've never seen that here. So I'm getting a different taste of the ICU, which is cool.
Yeah. That's actually really cool because I like getting a taste of all the different, I guess in Oakland, we had that one ICU, but it was cool getting a taste of different floors because I never did like a med surg or any kind of other floor like that. But I actually didn't really mind being floated. Everyone was so nice.
Oakland Hospital is nice. So we're getting into the ICU. We had our meeting and now we're going to start our shift. So usually if you have time, you could sit down with your nurse and get a little bit of like a heads up, look at the chart. If not, go to the room is what you're supposed to do, guys, of course. And you're going to start getting a report and disease processes. You give your report, you find out a little bit about the patient. I'm not going to go into details of how I give a report because that's a little too much, another episode, right? And I like to always look at like notes first. That's like my thing, just to kind of figure out what the heck's going on. And the longer you're a nurse, you already could start puzzling the picture together and you don't have to read all the notes. You're like, okay, patient is for this. I'm going to expect that. And then I just go into orders. Is that how you kind of start your day?
For me, yeah. For the most part, very similar to what you do. I get a report. I actually look at the MAR before I kind of look at notes. So usually get a report, look at my computer for a little bit, the more notes, then I hop on in, do my assessment, do my line recs, and after that, just start passing meds. Look at, also don't forget the nursing orders, if there's anything there, because the nurses do forget little details that, maybe you're supposed to restart tube feeds at 20 at 9 p.m. instead of restarting them at the goal at 40 or whatever. Just like little things like that there that aren't the most important thing in the world, but you also want to be able to take care of those kind of things, because even though it's not hugely important on their whole outlook, but you still want to give them nutrition, you still want to be safe because you don't want them to aspirate and just things like that. You just gotta be mindful of what you're doing. You have 2 patients, you have 1 patient. Try to look a little bit more in detail, and always try to go like a little bit of extra mile. Just do the stuff that you're supposed to. You don't have 6 patients. I know stuff gets busy. I know it gets crazy when someone's deteriorating, when someone's going to shit, but at least try to do everything that you can to your best of your ability.
I'm actually very OCD about that beginning of my shift. Like I'll look into the orders and I'm going to find out exactly everything, the rates, what I have to give. I'm going to look at labs right away just to see if I have to be careful for everything. And after I get that, orders, labs, I'll go do my assessment. I'll look at the tubings, making sure everything is good. And that assessment is priority because then I know the main thing that's going on with the patient. So then I'll prioritize that assessment for like the next 12 hours to kind of take a peek at it. Patient comes in for something related to respiratory. I'm going to prioritize that system for the whole entire night. And
yes.
Of course,
yeah. And don't forget about the one thing that really, pisses me off is when people put too much volume in the pumps. So check your drips, make sure there's enough volume, because when that shit goes dry, it's the most annoying thing in the world, especially if you have like 6, 7 drips going on and it's wide-sided. And then the one that went dry is the one that was being wide-sided. And now you got to be quick because that thing's a pressure, it's going to drop real quick. I hate that though. So always, when you're starting a new bag of fluids, new bag of any kind of medication, like take out like 20 cc's, put 80 instead of 100, put 240 instead of 250. Like don't put the full damn bag because that shit gets annoying.
You basically want your pump to give you a heads up like, hey, this is going to run dry in an hour, get an extra bag. And there's those nurses that put full. And I do mention this sometimes to them. If I see them the next shift, I'm like, hey, this is my pet peeve. Make sure you add less.
Yes. And if you're running low, it's always also courteous to, maybe request the drip for the next shift, which is also, nice, because pharmacy is amazing. God bless them. But sometimes they do drag dick a little bit. So at least request it. Like even when my bag is like half gone, I still request it for the next shift just so they can have it just in case. You never know. Maybe the bag's going to pop.
Pharmacy is the same way everywhere, man. Like it doesn't change whether I thought I'm going to come to this state and I'm going to see less of the issue of waiting for medications or things will be on time, things will be stacked. It's very universal everywhere. And I'm sure those guys are working hard. We should have a pharmacist on the show. I'm going to work on that one just to kind of see their perspective or how they feel when nurses are freaking calling them and blowing up that little cell phone about where's my med? And this guy's running around with like 60 different orders. Yeah.
I love pharmacy. They're amazing individuals, amazing people. And I know that in our shoes, it seems like it's taking forever, but you got to realize that there's one pharmacy and you got the whole hospital to cover. And some of these medications, they got to mix them, which sometimes takes like an hour. That's why it was good to request it earlier. But God bless their souls. I like pharmacy. They're a bit cool. I haven't had an issue with them. If my drip's not there in an hour, I call them, hey, what's going on? Maybe they're just saying, yeah, we're tubing it right now. They tube it. Maybe they forgot. Just remind them. Because pharmacists, don't yell at your pharmacist. Don't get angry because one day you're going to have a question with pharmacy. You're going to look up your drips and you're going to see which one's compatible. And guess what? Computer says that not tested. Well, shit, it's not tested. So what do you do now? You're going to call a pharmacist. And you don't want the pharmacist to be like, I don't know. You actually want them to take the effort and actually look it up on their end, see if it's any different.
Definitely. Maintain those relationships, guys. I'm yet to explore which pharmacist I work with in my shifts. So some tips and tricks when it comes to nursing, right? One thing I would definitely do is if you're going into ICU, go get your ACLS to kind of save you some time because that's a requirement. And if you're in the ICU, you're new, make sure you prioritize and learn the algorithm of ACLS. Like, it will come back all the time. Even if I'm on telly sometimes, like I have to utilize my ACLS, and it's going to save you a lot of anxiety and stress, like figuring out what to do, how to troubleshoot, even like in emergent situations.
When you think of the ICU, a lot of people imagine these very sick, ill patients. They are very sick, they are very ill, but they don't code every day and all the time. That's why ACLS is important, because you are going to have a code situation in your life, and it's good to be prepared. And the more people that are ACLS prepared on your unit, the smoother the code is going to go. The ACLS prepares you for literally everything. If someone's going Brady, if someone's going tachycardic, if someone's losing a pulse, maybe they're tachy, but they have no pulse. Maybe they're tachy and they do have a pulse. Maybe monitor showing 80, but they really have no pulse. So it kind of prepares you for everything. It's a good rundown. And even though we're required to take the class, I think once a year or once every 2 years, it's a really good refresher every time I take that class, just because you can't remember everything. That's why it's like a kind of like a high mindset. Like if everybody knows something about the ACS protocol, you can help each other out. But it's very important for you to know, especially in the ICU, because some ICUs, you are the code team. And if you're in ICU, you are running your own codes, or you're going to other units to run their codes.
Definitely. And even like here in the ICU, once I've seen little things like we did a mock code or I was intubating a patient, it's funny how their standards of ACLS changes too. So it's good to know and adopt those. For example, we intubated a patient, and back in Chicago, we usually connected a piece to the where the breathing tube is during intubation, and it would give us a CO2 reading. They don't even do that here. They connect like a color, and it blows a specific color to let them know that they're in the lungs, which kind of blew my mind, because I kind of mentioned it. Hey, you guys didn't check a CO2, and they kind of pointed it out, their way of doing it. So it was so cool.
That's when they do that instead of like the CO2 cable, or do they do that instead of like an ABG?
They do that instead of CO2 to kind of make sure they're in the lungs. So they're not looking whether it's above 20 to get like ROSC and things like that.
That's actually really cool. We have the CO2 monitor, which I heard isn't like the most reliable thing. But for me, I've never had one fail. But I have heard of the colored one. I've never seen it though.
It just, they do different evidence-based things. Like sometimes instead of like doing heparin, they do the anti-XA instead of the PTT. Also about ACLS, which big things. Know your H's and T's, and knowing when you're running a code too, like think about those H and T's, because you could help the doctor, because sometimes they're not thinking about stuff like getting the sugar. Are they hypoxic to begin with? Maybe you have to replace the bicarb. Things that during a code that are happening, you're trying to reverse those causes that put the patient in the first place, that cause like the pulseless VTAC or VFib.
Yeah, so the H's and T's is what we call them. I'm gonna go over them with you real quick, just so you guys know them. I'm gonna read off this thing, just so I don't want to get them wrong, because I don't always have them memorized, but we just kind of troubleshoot as it is. And especially if you're working like a specialized unit, you kind of know why they're going into cardiac arrest. Especially if it's like maybe they have a renal issue and their potassium is like 7, and now they're like in VTAC. That's probably like going to be your sole cause. So when you work on a specialized unit, you're going to be kind of more familiar why your patients deteriorate. But according to ACS protocol, the H's and T's are hypoxemia, hypoglycemia, hyperkalemia, tension, pneumothorax, toxins, tamponade, and thrombus or an MI. And it kind of, we'll do a really quick rundown on how to kind of treat these issues. But hypoxemia, it's usually someone's respiratory failure. Most likely they do need to be intubated. Not most likely, they're all going to need to be intubated. And that kind of fixes the resolution. Some things maybe, I know there's some kids with what's called like epiglottitis or something like that, where their throat seals, and that would be a cause for hypoxemia. So you intubate them, get oxygen to your lungs, and that treats the cause. Hyperkalemia.
And sometimes to diagnose, they just check an ABG, guys, arterial blood gas, gives you guys a reading. If his pH is basically not compatible with life, we need to put a breathing tube in. What's the next one?
Hypoglycemia. I've never literally seen anybody code due to hypoglycemia, but if you're not paying attention to the sugars, if you're kind of, half-assing these blood sugars and insulin, maybe your patient's NPO sugars have been running low, nobody adjusted the sliding scale. You forgot that an NPO, and guess what? You gave them the 20 of Lantus, plus you cover their sugar of 151, and now they're hypoglycemic in the code. So quick fix is dextrose. Hopefully it doesn't happen to you. Hopefully if they're NPO, you're doing sugars Q6. But I've never actually had anybody code that's hypoglycemic.
I've seen somebody being like basically lethargic and somnolent without like sternal rubs, dude. And you push an amp of D50, like 30 seconds later, it's like Narcan, man. These people like wake up and like, what's going on? So definitely you could get comatose and knock the heck out with, having low blood sugars, but it's pretty preventable.
Yeah, for hypoglycemia, I'm sure that's something that happens more out on the field where people don't have good blood sugar regulation and they code. But in a hospital, we're pretty strict on sugars. You're either ACHS, Q6, we're like you're critically in critical health. So you're highly prioritized, highly managed. The next one is going to be hyperkalemia. For that, we usually I see insulin and glucose. You got to give glucose because you give a person insulin. It's going to drop their sugar. So you want to make sure they don't go from hyperkalemia to hypoglycemia, and then you're coding for hyperkalemia and hypoglycemia. So that's why we give insulin, because it puts potassium into the cell, and then it decreases the potassium in your bloodstream. Right? Am I correct on that one?
I think you could. Damn, we're about to be troubleshooted here. Yeah, you're right. Potassium gets pushed inside of the cells for hyperkalemia.
Right, because you're testing blood, so obviously it's going to have potassium in the blood, so you got to push that bad boy in the cell.
Exactly. Next one, tension pneumothorax, guys. That's when basically your lung collapses on one side, your trachea deviates to the side, and before even troubleshooting those little symptoms of like anxiety, like you're going to see the patient's throat move. They're going to be short of breath. They're going to desat a little bit. Then you might need some oxygen. They might feel pain here. Those are pretty simple. We need to decompress that. Usually they put a chest tube in. Sometimes they'll put a needle. That's more out on the field.
Yeah, for the pneumothorax, I've seen it happen when somebody pulls a chest tube. It's a pneumo forms and it kind of gets bigger. They didn't seal it off properly, or it didn't heal quick enough, and now you have a pneumo forming, but it forms slowly. A little bit of air is getting in there. And that turned into like a severe issue when a patient becomes shortness of breath, trachea deviates, you get diminished lung sounds on one side, and then you got to put the chest tube back in.
That's right. When they're going to bounce into toxins now. Toxins could be anything from drugs, from too much Tylenol, whatever it is, basically reverse it. If it's heroin, give them some Narcan. There's really not much about toxins, right? Tamponade, basically your pericardial sac, which is a sac that the heart sits in, it becomes fluid overloaded. And the way fluid builds up, the heart can't beat as well, and you have to decompress that. And we have those like typical 3 signs, right? Hypotension, muffled heart sounds, and like a Beck's triad. Oh, it's called Beck's triad. And then there's also muffled heart sounds. Sorry. I've never seen that one personally. I don't know if you did PD, but just basically have to decompress the sac.
I have, but I was not the primary nurse, and my patient wasn't doing too good themselves. So unfortunately, I did not see them, do a pericardiocentesis. But it's basically like if you imagine a chest tube, it's similar. It's what they're doing is basically almost the same thing. You're draining fluid from the pericardial sac. So you got to insert some kind of line in there to drain that fluid. And then it's not as big as a chest tube, because I know chest tubes have those big chambers and they sit on the ground. This one's usually like a small needle insertion where it just kind of, I guess you could say, decompresses it with the fluid removal, and it goes to like kind of almost like a JP drain kind of thing. Almost, it looks like. Yeah,
it's. I don't think it's as prevalent. It's preventable with a lot of nowadays, because of where medicine is, it's very preventable. We don't see it as often. And the last T is thrombus, and that's basically having a heart attack, myocardial infarction. You want to basically get the patient down to cath lab if that's possible, or try to resolve what is causing the occlusion. That's, your heart is not getting the oxygen that causing you to possibly be pulseless.
I mean, the best way to really spot MI, I guess, from an ICU standpoint would be, I guess, a change in rhythm. Are they having, YT complexes? Are they elevated? What's going on with the heart rate? Does the rhythm looks different? And of course, chest pain, things like that. But usually I don't really see very much MIs. Like I said, it's like with hypoglycemia, you see them more out in the field, because when someone has an MI out in the field, you should bring them in, take them to the cath lab, they get stented, put in anticoagulation, and the thrombus is actually removed, or it's they give you TPA where it eats the clot up. So those things are more of a very acute setting, unless your person is very, very sick and not anticoagulated.
I feel like most cases that we see in the ICU, it's more respiratory, and it's more like rhythm changes that we have to troubleshoot, because like their ejection fraction already sucks and their labs are out of whack, which causes the ventricular rhythms. I think that's the most that I utilize my ACLS for.
Yeah, that is same here. That's correct. I actually it wasn't really ACLS because we have atropine like PR and on standby with people that come in with certain issues. But I did have was my patient, it was my buddy's patient a couple of nights ago, that they put on amiodarone because she initially came in for hyperkalemia, had a bunch of runs of VTAC, which we know hyperkalemia can cause to go to a VTAC, a post-VTAC, and a potential cold. So we started her on amiodarone. Actually, it was hypokalemia, not hyperkalemia, that she came in for. So we gave her a bunch of potassium. She had some runs of VTAC. Obviously, those got better when the potassium came back up. But then we started her on amiodarone, and she had a very good response to amiodarone, actually too good of a response, where she became bradycardic. So bradycardia is a heart rate of less than 60. And when we sleep, our heart rate does tend to go below 60 if you're a really healthy individual or you're an athlete. Some athletes have a heart rate of 50. I know I have a lower heart rate when I sleep due to my Apple Watch telling me what it is. So bradycardia for me is normal. There's no reason for me to be reversed. I'm not gonna have atropine on standby next to my bed in case I go to 55 because it's below 60. That's not how it works. So above everything, you want to make sure that the monitor is correct. So go assess your patient. You see a heart rate in the 40s, 35s, go assess them. Are they symptomatic? Are they complete with it? Are they the same person that they were before? Do they know where they're at? Do they know their name, first name, last name? They know date of birth? Do they know which president? Just ask simple questions. If they're the same, what about their blood pressure? Is it fine? That's considered asymptomatic bradycardia. So you don't really got to do much for that besides monitor. Maybe they're on amio for their AFib RVR, which is atrial fibrillation with rapid ventricular response. That's why they're on amiodarone. And amiodarone does tend to cause bradycardia occasionally. So maybe that's just causing that, which is nothing crazy to get worried about, because you're more worried about them going back to AFib RVR versus the Brady at 50 or 55. But let's say you go to patient's room, they got an A-line in, and every time they Brady, when they go, normally they're in 70s, but every time they go to Brady in the 40s and the 30s, their pressure drops. Normally they're in the 90s above 60s. Now they're 70s above 20s or 60s above 40s, and they're not really with it. This would be a good time to push atropine. And atropine you give 0.5. That actually happens to my buddy's patient, where started him amiodarone, started him on all these drugs, and her rhythm dropped to 30s, and her pressure dropped with it. Thankfully, she had an A-line, so we knew what it was. We pushed half a milligram of atropine, had a great response for it, was good for maybe 10, 15 minutes. After that, back down to the 30s, hypotensive. We had to stop some of her sedation, gave her a dose of atropine, and then we eventually started her on dopamine, because dopamine is actually a pretty cool drug. It could be used as a pressor and also as an inotrope. So it could raise your blood pressure and also could have your heart beat a little harder, which eventually...
Is it in small doses that increase the heart rate, or do you have to give a larger dose for the dopamine to work?
See, that one I forgot. We give her a low dose. So I'm pretty sure the low dose is going to be the inotropic effect, and then the higher dose. Don't quote me on this. I'm not even going to say anything. I'm not even going to say anything because I'm not 100% sure. I know at certain doses, it's inotrope where it helps the heart contract. And at certain doses, it's a pressor where it increases the heart rate. So your patient's going with Brady, asymptomatic, he's probably fine. If your patient's Brady, symptomatic, per ACS protocol, technically could give atropine in ICU, 0.5 milligram.
And then worst case scenario, sometimes we go into the pacing where we just put some pads on and we kind of increase the heart rate based on electrical conductive system when the medications don't work. And we could do that same thing with like VTAC and VFib guys. So those are both shockable rhythms that we try to get the patients out of. And essentially when it comes to ACLS, we shock these people just to try to reconvert their electrical system to start freaking pacing properly. That's why those H's and T's come in like clutch, because we try to reverse the things that puts the patient there, like bad pH, give some bicarb.
We did have the patient on pads just in case, but she responded very well to the atropine 2 doses, and she actually responded very well to dopamine. So we didn't need a pacer, but we did get orders from one of the cardiologists that we could transcutaneously pace if we need to. And some places have, like the pacer boxes. You could also pace out the crash cart. Your crash cart is going to have all the medications that you will need: atropine, epi, amio, everything that they will need is going to be there. Bicarb, and also everything you need to set up lines, sterile gloves, just sterile, things you put on patient drapes, and you could pace your patient through the crash cart because it has like that giant monitor. I forgot what's it called, but you could pace somebody, you could shock them with it, you could do everything with that before because it's an emergency situation. You could bring it in, do it real quick, and then you could transition them to the pacer box when you get one.
When you guys do your codes, do you guys put it on AED mode, or is it just on the monitor?
The one on the crash cart?
Yes.
The only modes that we have on there is defib and then synchronize, and then pace.
My question is what I'm noticing is when I worked at the previous ICU, we always went on AED mode. So meaning when you're running the code, there's a guy telling you, hey, shock the rhythm or analyzing heart rhythm. The reason why I ask is here, they don't use that mode. They just put it on and they do the shocking themselves based on the physician.
No, we do not have any kind of machinery telling us what to do. It is us doing what needs to be done.
Okay, it's an AED mode. It's beneficial for some people. So ACLS guys, that's just basically the wrap up of things. One big thing in the ICU that I'm noticing, on top of knowing your skill, knowing your shit, and basically being able to be a good nurse in the ICU with, doing labs, giving a report, all that, is teamwork. And I think it goes unnoticed, the amount of teamwork that it takes to be an ICU nurse. What would you say? You think teamwork is a huge quality of an ICU nurse?
Well, definitely teamwork. Like I said, even though we're all ICU nurses, each of us might have a different background in the knowledge. Some of us might have seen different things than others. And it's always good to work together. It's always good to ask questions and troubleshoot. It doesn't matter how long have you been there for. It just, you don't know everything. You haven't seen everything. It doesn't matter if you've been there for 20 years, you for sure. Even if you're not specialized, you for sure haven't seen anything. It's always good to ask questions, talk about it, talk things through. And even if you're a new grad, it's okay to talk it through with new grad, because think about it, they're new grad, so they haven't seen as much as you have. So they might open up different doors, different pathways to like your thought process. Maybe they might think of something that you haven't really thought about. But teamwork is definitely huge. Teamwork is definitely huge, especially when you got a heavy set patient and try to turn that patient by yourself. It ain't gonna work out very good.
And I would definitely say when it comes to teamwork is bouncing those ideas around that you mentioned. There's so many different cases of different patients that sometimes you did this one way. Sometimes you have to do it another way based on your scenario. And like we as nurses doing the teamwork part, we're always bouncing ideas and telling, hey, maybe you should do this instead. And I always have those few nurses, and I'm learning those nurses here where I'm always coming and I'm giving my scenario and they always give me some awesome feedback. And usually it's great because, two minds work better than one.
That's where it's at. And, sometimes you get the lesser, heavier assignment, or your assignment's less heavy. And you should definitely be that nurse that asks, or not asks, but just does extra mile and just helps other nurses. Like, you don't want to be struggling and then have nobody to help you because you've been a dick the last 4 years that doesn't talk to anyone, doesn't help anybody. No, it's not good. It's not gonna be productive. That's not going to lead to good patient care. It's just you're going to be miserable because your patient is going to crash. So it's always good to help out somebody when their patient's crashing because they usually reciprocate with the same help.
And then sometimes you have those cases where you're in isolation gown and you have to flag a nurse down to get you supplies. So you don't want to be that annoying kind. So always kind of like when I have downtime, I always kind of like go around the unit and ask, does anybody need help? Especially being the new guy around the block, I try to do that just to kind of build those good relationships.
Of course, that happens to me all the time. I literally forget everything. I don't forget everything. Like when you go to ICU room, I always end up forgetting something. It's like a pair of gloves or like a Nutrig tie or something like that. And I'm always flagging somebody down. So what I try to do is kind of I do my assessment, see what I need, and then I kind of bring whatever I need where I'm sitting, just so I have it, so I can walk in the room next time I go in there.
That, and I'm trying to think what else is another. Do you think there's any other cool little tips when it comes to teamwork? Oh, there's no tech usually in the ICU, so we're always going to have to be helping each other out. So if people think that they go to the ICU and they could be, like lone wolves and take care of business, it's not going to happen. Like those nurses that you work with, like make sure you guys have awesome relationships because those relationships could carry over, outside of the hospital, and you guys could be awesome friends. But at least as coworkers, you guys have each other's backs. And when you have like those awesome nurses, when you start your shift, it's going to be a good shift in the ICU when they're around. Because regardless of a bad night or a good night, they're there to always crack a joke and things like that.
You can't beat, a good work environment. Can't beat it. It's a pretty good episode. You want to touch on anything else?
No, I think we should wrap this one up.
Yeah, I wanted to talk about some VTech and VFit, but I guess we'll save that for next time.
We could touch about it.
That's okay. We'll get them next time because it's been for a little bit. So today, guys, we talked about a cool drug called ketamine that's in the works for treating major depressive disorder and also treating depression that's resistant to your other antidepressant medications like your SSRIs and triclic antidepressants. And then we talked about how to kind of go through a code, the H's and T's of the ICU, and how to be a good ICU nurse and how to prep for the ICU, and a little bit of ACLS as well, and teamwork. Can't beat teamwork.
Can't beat teamwork, guys. And ACLS, know it, love it, study like a Bible. We didn't go over the meds, I'm noticing, but I think we could touch about another episode. But definitely know everything as a whole, and that's going to make you a great nurse. And not only that, but be humble and don't be afraid to ask questions. Don't be afraid to develop those strong relationships. Don't be afraid to help other nurses. Sacrifice the time for others, and they'll scratch your back because you all need somebody in the battlefield to kind of have your back, and the ICU is a battlefield.
All right, guys. Have a good one. See you next Friday.
Take care, guys.